So I'm delighted to talk with you all today about a topic that is sort of what gets me out of bed to go to work in the morning or at night when I'm catching babies, and that is the importance of the fourth trimester. I'm going to start with a couple of disclosures. I have a couple of financial relationships with funded research that I'm not going to speak about today. I have received or currently receive research funding from a variety of sources. And perhaps most important to today's presentation, I have 3 children, and I've breastfed for a total of 10 and a half years. And I share that because I think when we think about the postpartum period, one of the things that makes this so powerful and also so challenging is that our own lived experience is so close to our own hearts. And so these are my 3 boys. Noah, my eldest, was born the night before the match when I was a 4th-year medical student. Sam was born the first day of my research block when I was a 3rd-year resident. And Max was born 3 weeks after I started working at UNC. And so my experiences of postpartum period with Noah meant moving to a new city and finding a new place to live and unpacking and getting situated and then starting residency. For Sam, I had 6 weeks, and he was a child who did not sleep unless mommy was holding him. And so my feelings about baby sleep are very informed by my Sam experiences. And then with Max, I had a delayed postpartum hemorrhage that was not initially recognized and involved a fair amount of unhappiness for all involved. So when I'm counseling mothers, they see me as Dr. Stubbe, but I am mom of 3 boys who had these postpartum experiences. And I think it's really important for us to be aware of that distinction between our role as healthcare providers and our lived experience as mamas. Many of us have been mothers. Lots of us have been parents or aunts or uncles. All of us have been babies. So all of us bring lived experience to this work, and it's really important that we acknowledge that and be careful not to let that become medical advice for our patients when we don't make that clear distinction. So without further ado, today we're going to talk about the developmental and evolutionary rationale for the 4th trimester. We're going to review the prevalence of unmet maternal health needs. Spoiler alert, there are a lot of them. And we're also going to talk about how structural racism and implicit bias contribute to inequities in 4th trimester health. And I think that the events of the last few months have brought to the attention of many of us who might have been able to remain ignorant of the roles of racism and implicit bias in folks' lived experience. It's become really obvious now. You can't not know it's there. But it's been there for a long time, and undoing it is going to take directed efforts on our part to really listen and hear and be present. And then finally, we'll talk about some recommendations to improve support. So why 4th trimester? Those 3 boys that I have already introduced you to have pointed out to me that trimester means 3, and so there is no 4th trimester, and that's ridiculous. But in fact, I think thinking of it as a 4th trimester reflects the extent to which we've not appreciated the importance of the days and weeks following birth to the well-being of mom and baby. There's this sense that you have the baby and then you're done. And in reality, that's really where the work begins. And we can understand this when we think about evolution and strategies for survival for mammals. So when biologists talk about different evolutionary strategies for mammals, they often separate altricial species from precocial species. So here on the left, these are baby mice. Mice are altricial. They're born hairless with their eyes fused and with very little capacity for doing much of anything except finding a teat and attaching to it. And this is a common strategy for carnivores or for animals that have to hunt for food, because if you're super pregnant and you're out hunting, it's going to be really hard to get food. So animals will birth a litter. That litter can stay together and keep itself warm while the mama goes out to eat and feed and then comes back and feeds them again. It's very different from precocial species. So this is April the giraffe. Many of you may have followed April's labor, which was live streamed on a webcam. And this is her newborn giraffe at about an hour of life. So precocial species are born quite mature. And this is often the case for herd animals. So giraffes in the wild, you have to be able to walk with everybody else pretty quickly, or else you're going to get left behind. And so precocial species are born with much greater capacity to independently support themselves. Primates don't really fit in either category. So this is my niece Ayla. She's now 5 and she loves unicorns, but at this point she was a newborn. And the human babies have often been referred to as secondarily altricial, in the sense that they are not able to walk within an hour of birth. But they can open their eyes and they can engage socially with their caretakers. And in fact, one of the things that human babies are really good at is looking adorable so that humans want to take care of them. That's important because otherwise they're a lot of work. And if there wasn't some kind of positive feedback, you can imagine a lot of adults would say, like, why am I doing this exactly? So when we think about why human babies are born so premature in terms of their ability to function in the outside world, there are a number of different theories. And for those who are interested, this book, Costly and Cute, is a wonderful overview of different anthropologic theories of why human babies are the way they are. And one of the ones that I found most fascinating is this idea that there are advantages to having growth occur in the stimulating environment of the outside world and a dense social network. So human babies have more brain growth after birth than any other primate. Now, on the one hand, for obstetrics, that's a good thing, because if a human baby's brain were as mature as another primate brain at the time of birth, that head would be the size of a 3-month-old. I have been on nights on labor and delivery earlier this week. I've caught lots of babies, and it's a whole lot of work to push out the head of a term human infant. Pushing out a 3-month-old from a mama's pelvis would be pretty close to impossible. So it's been argued that maybe human babies are born with relatively undeveloped brains so that they can fit out the birth canal. But I think the second issue is really fascinating, because what it suggests is that the human brain goes through these critical developmental phases with language, with social interaction. And so human babies are smarter because their brain develops while they're on the outside. I think that also points to the critical importance of helping mamas and providing them with support. Because if a mom is coping with anxiety or depression and struggling, she's going to be less able to engage socially with that infant. And if a mom has to go back to work at 10 days postpartum because she doesn't have paid leave, no one's going to be engaging socially with that infant. So investing in the well-being and support of mothers during this time period and caregivers then allows infants to benefit from this important period of brain growth. There's another really important distinction between us and the other primates. This is a mama gorilla, and you can see her baby is hanging on beautifully to mama's coat. And so this baby can nurse whenever she wants, on demand, on cue, no problem. And mom can go about her regularly scheduled program because baby's hanging on. And you can see mom's teeth right here. Human babies are adapted for suckling on demand or on cue. Human milk is composed in a sense that's normal to feed like every hour. But human mamas can't carry their babies this way. We don't have hairy chests. And although our babies have a grasping reflex, they can't hang on to the smooth chest of a human mama and breastfeed whenever they want to. So the anthropologists proposed that one of the first inventions of Homo sapiens was probably the baby carrier. And that's why in cultures across the globe, there are different techniques for carrying a baby so that human mamas can essentially do what this great ape is doing here. We also know that humans need a village, because we can't be hunter-gatherers and feed a baby that needs to be held all the time at the same time. And so the anthropologists further argue that the reason that human babies are so cute when they're born is because they need to engage not only mom, but the other grown-ups and the other alloparents in her circle. So it really does take a village. And again, wearing my obstetrician hat, it would be much easier to push out a scrawny baby that didn't have fat cheeks, but that baby would be less interesting to the other grown-ups. And so our babies are born with this social skill and this appearance that engages other adults to help to care for them. And I'll often share these anecdotes with parents. The mom will think that she's failing because she can't do it all herself. And I'll say, no, you're not supposed to do it all yourself. You don't have a hairy chest, so you need a baby carrier. You don't have a hairy chest, so you need other adults. And so you're not failing when you ask for help. You're actually doing what we are evolutionarily supposed to do in order to thrive and be successful. So in light of this need for support for moms and babies to thrive, the 4th trimester is critically important. And way back in 1975, when I was 2, Sheila Kitzinger said there was a 4th trimester to pregnancy and we neglect it at our peril. Kitzinger was a feminist advocate, childbirth educator, and she appreciated that we desperately needed to provide support for moms during this critical period. She wrote that it is the transitional period of approximately 3 months after birth, particularly marked after first babies, when many women are emotionally highly vulnerable, when they experience confusion and recurrent despair, and during which anxiety is normal and states of reactive depression are commonplace. And it's somewhat disappointing that 45 years later, I'm giving you a talk to talk about how it's important to take care of moms in the period after birth, and that isn't a given, that isn't the standard of care. And I'm hopeful that I can convince you we need it to be if we want moms and babies to thrive. So what are some of the challenges that mothers face? Well, the most serious is mortality. And we know that more than half of pregnancy-related maternal deaths occur after the day of delivery. So these are data from the United States that show that about a third of deaths occur before delivery, about 17% on the day of delivery. And you can see that more than half occur after the day of delivery. And a third occur after 7 days postpartum. So arguably these 1 to 6 day postpartum complications and mortality may be a birth complication that mom survives the day of delivery, but then unfortunately passes away in the next couple of days. A large proportion happen after one is discharged to home. And so if we want to address the maternal mortality crisis in this country, we have to address care after the baby is out. Mortality is obviously the worst possible outcome, but there's also a lot of straight up misery that happens in the weeks following birth. So these are data from Listening to Mothers 3, looking at the major and minor health problems that moms struggle with in the first 2 months. They include breast infection, hemorrhoids, pain with sex, headaches, bleeding, depression, backaches, sore nipples, lack of sexual desire, other breastfeeding problems, weight, physical exhaustion, feeling stressed, and to no one's surprise, more than half of mothers report sleep loss as a health problem in the first 2 months after birth. So we really need to be thoughtful about these different issues that moms are handling. And when we think about all of this morbidity and question what support we provide, the answer is not much. And I've sort of become known for saying that the baby is the candy and the mother is the wrapper. And once the candy is out of the wrapper is kept aside. That is not how it should be, because moms are people and women deserve care even when there isn't a baby inside of them. But the reality is that many of our social traditions, like people bring baby presents, they don't bring mommy presents. And then the way that we think about care, babies are seen multiple times in the first weeks of life. Moms are seen weekly up to birth, and then postpartum, good luck, we'll see you in 6 weeks. And you can figure this out as you go. And that's a tremendous problem. Listening to Mothers found that 1 out of 4 mothers did not have a telephone number of a care provider to contact in the first 2 months after birth when they left the hospital. So a third of deaths occur more than a week after birth, but 1 in 4 moms don't even have a phone number. Whether someone answers the phone and gives them the right answer is a whole other question. But there's a tremendous disconnect between what moms need and what moms receive. We also know that a lot of mothers don't get a postpartum visit. So these are data looking at proportion of women completing a postpartum visit at 3 to 8 weeks postpartum. And what you see here is that it was particularly bad in the mid-2000s, but even out to 2017, the most recent data, only about 65% of Medicaid moms have any postpartum care. So these women have a baby and then they don't come back to healthcare until they're pregnant again, which is deeply problematic. For those who do have a postpartum visit, we do a pretty crappy job of providing moms with the information they need. So one of the questions in Listening to Mothers was, if you had that postpartum visit, did you get enough information about common topics? So the only thing that breaks 60%, which is a passing grade, is midwives talking about birth control methods you can use after giving birth. And I'm not going to argue that that isn't important. But what about changes in your sexual response and feelings and how long to wait before becoming pregnant again? It's kind of hard to talk about birth control without talking about sex and when to get pregnant again. And yet those topics are not covered consistently. There's also less than 60% get information about postpartum depression, about exercise and healthy eating. So when moms show up, the support they're getting isn't meeting their needs. It's also important to appreciate that some of these needs are really concrete and practical. So this was a study that looked at the proportion of low-income women I believe it was in New Haven, Connecticut, who supported not having enough diapers for their baby, not being able to afford enough diapers. So 27% of moms surveyed didn't have enough diapers. And they were asked, what did you do about that? Well, about a third went to an agency, a third borrowed diapers or money, 12% did something else, 27% stretched diapers. And so what that means is your baby has a poopy diaper and you don't have enough diapers, so you leave that poopy diaper on. And the baby smells bad and the baby's crying and you know you don't have a diaper for that baby. If you think about what that does for postpartum depression, it's pretty terrible if your baby's in a stinky diaper and you can't afford to change that diaper, and so you have to smell that and listen to your baby cry. And so when we think about assessing mom's needs, it's not just a matter of asking about her health, but also about does she have what she needs to take care of the baby. The National Diaper Bank publishes data about the cost of diapers. And what you see here is that in California, the TANF benefit is actually more generous than the United States on average. A family of 3 with 1 parent and 2 children gets a whopping $714 a month to cover all of their expenses. I know y'all are in the Bay Area. It's pretty hard to find a place to live for $714 a month. But 11% of that just goes to diapers. It costs about $80 a month to get diapers. So when we think about, and diapers are not, there's no benefit for diapers you get sales tax on. And so this is a real issue. And so I would encourage you all to think about, where is your local diaper bank? And is that information provided to your patients? And is that information just provided regardless of payer status? Because particularly in this time of COVID, when unemployment and limited income is affecting everybody across the board, it's not helpful to say to patients who look like they might need diapers, oh, you know, there's a diaper bank. Probably more relevant to say diapers are a concern for lots of families. If you're unable to afford enough diapers, there's a diaper bank. If you happen to have extra diapers, you can donate to the diaper bank and support other families. And so then you're not saying, gee, you look poor, so I'm gonna give you diapers. You're saying there is a diaper bank, and if you have too much or too little, this is a resource that might help you. I think more globally, we have this problem of the way that we take care of moms and babies. So this is a beautiful image of a mother nursing her baby. And there's an obstetric provider who's taking care of mom. And that OB provider, you know, is taking care of mom, is taking care of, you know, her bleeding, taking care of her pelvic floor. But often they're like, that breast that's in the baby's mouth, that's not really my problem. I don't think I really want to deal with that. And then there's a pediatric provider who's taking care of the baby. And the pediatric provider is interested in breastfeeding because that's what the baby's eating, but they're like, that breast is attached to mom, so if it's like cracked or whatever, that's not really my problem. The exception here are family physicians and midwives who actually are trained to take care of the mom and the baby at the same time. But at least in my part of the country, that's the exception and not the rule. And so most of the time, there's a mama provider and a baby provider. There is a lactation consultant often, and lactation consultants are amazing in many, many ways. They're particularly gifted at understanding what I like to call the orobubular interface, right? So the mom's boob and the baby's mouth. But it's outside of their scope of practice to think about, for example, what if mom has depression? What if she has anxiety? What if she has bipolar disorder and going without sleep triggers mania for her? Well, then the advice to feed on cue every couple of hours during the night is not going to sit well with that mom. Mental health providers are really good at mama's brains, but they may say things like, you need to sleep for 10 hours, even though you're breastfeeding and your breasts are going to explode if you do that, and they won't necessarily propose a strategy for draining the breasts periodically during the night so mom doesn't get a terrible case of mastitis. Family planning folks are very focused on mom's uterus and not having anything else get in there, but they may not talk about the potential side effects of hormonal contraception for milk supply or for mood, for that matter. The vast majority of moms don't see those side effects, but some do. And if mom has said, yeah, the pill makes me crazy, then giving her an Explanon might not be a great idea. And we need to take that into account. So we have this problem that there are all these different providers, and not only do they have a different context, but they may be in different zip codes, in different medical office buildings, on different electronic health records with different copay policies. And so no one's talking to each other, and mom ends up being fragmented into all these different pieces. So with the fourth trimester project, we took a look at all these different intersecting areas, and we said, okay, there's mood and emotional well-being, there's infant care and feeding, there's sex, contraception and birth spacing, there's sleep, there's physical recovery from childbirth, and then there are medications and substances and exposures. And each of those are often dealt with individually, when in fact we need to recognize that all of these issues overlap. So we submitted this image to a journal where we were publishing a commentary on the fourth trimester, and one of the reviewers said, your image is too complicated, you need to make it simpler. And we said, with all due respect, the postpartum period is complicated, and we're not going to make a simpler image so that the reader is happy. We need to recognize that there are all of these overlapping and intersecting issues. And so I think one of the challenges is to think about how do we address all these different moving parts in a way that's centered on the mom and her needs and her concerns, rather than saying, well, I'm all about contraception, I don't care about the rest of you, I'm going to recommend this birth control. So when we think about the impact of the lack of postpartum follow-up and the fragmentation of postpartum follow-up, there's some very real consequences. If we don't see mom for 6 weeks, it's really hard to address her breastfeeding needs in the first couple of weeks of life. And so that's going to lead to early cessation of breastfeeding. If we don't see mom at all, and we don't initiate a contraceptive method that's compatible with her needs, she may have an unplanned short interval pregnancy, and that has significant consequences for her. It's also associated with adverse outcomes for the next birth. If her depression and anxiety are undiagnosed, we're not going to be able to treat them. And I don't need to tell this audience that it's a really bad thing to have depression and anxiety and not get treatment for mom, and also for the development of her child. And we know that short interval pregnancies are associated with preterm birth and infant mortality in a subsequent pregnancy. So there are a ton of reasons we need to do a better job with postpartum care. In light of that, back in 2018, the ACOG Postpartum Task Force proposed a new approach to thinking about postnatal care. So the old paradigm was a 6-week postpartum visit. And I was the chair of this task force, and we spent a lot of time trying to figure out where did this 6-week postpartum thing come from. And one of the senior folks at ACOG said, well, the first postpartum visit was when Mary brought Jesus to the temple at 40 days postpartum. And I was like, you gotta be kidding me. But actually, when you go back to the Bible, that references to Leviticus. And in Leviticus, it was recommended that boy children stay home with their mothers for the first 40 days. And actually girl children were for 80 days because girls are more sinful because of Eve, which we won't get into right now. But there was this prescription that for at least 40 days, mom and baby were supposed to be home and cared for and recovering. In Latina culture, there's La Cuarentena, where women are expected to spend 40 days surrounded by family and friends. In Asian culture, there's doing the month, where folks are expected to stay home and be supported for the first month. And there's specific rules and taboos about what moms can and can't do. So if we lived in a world where moms were cared for and looked after for the first month to 40 days of life, it kind of sort of makes sense to say, well, when that's done at 40 days, you go out to your doctor and get blessed to go out into the world. But the reality is for so many moms, they're supposed to be in their snapback photo at Target by 7 days postpartum. Or they don't have the option to take that time off and they're back at work. And so we've kept this vestigial 6-week postpartum visit as though there's a traditional period of rest and recuperation, and that period is no longer with us. So what we proposed with ACOG was that there is a 12-week period during which mothers need a primary maternal care provider who's responsible for the woman's care and for answering questions that come up. We argued that we would like to see contact with all women, and we chose the word contact, not a visit, because that could be digital, that could be a text message, that could be a phone call, to check in on how things are going. And then ongoing follow-up is needed through 12 weeks. There are some mothers who need an earlier contact point. ACOG and SMFM recommend a blood pressure check within 3 to 10 days for moms with gestational hypertension and other hypertensive disorders. In the era of COVID, that can be digital. So mom checks her blood pressure at home and checks in with somebody on the phone, but we need to be monitoring that. And that again gets at that issue of maternal mortality that moms can stroke or seize if they have untreated hypertension and they're at home. And then there are moms who need some touch point in the first 1 to 3 weeks. The mom who has a history of terrible postpartum depression or postpartum psychosis needs to be checked in on, probably with at least a real-time video visit, if not an in-person visit during that time period. And then sometime between 4 and 12 weeks, when things have settled, moms need that sort of put a bow on it comprehensive postpartum visit. But that shouldn't just be at 6 weeks because Mary took Jesus to the temple at 40 days. That might be at 4 weeks for the multip who has an uncomplicated vaginal birth with no tears and is doing great. That could be more like 10 weeks for the mom who has a C-section with a wound blockage. But we need to really individualize it. So that's sort of the goal that ACOG set forth in these guidelines. And I'm going to shift gears for a minute and talk a little bit about the effects of structural racism and implicit bias and their impact on disparities in fourth trimester health. I give this talk fully aware that I do not have lived experience as a woman of color, and I've tried to educate myself, but I would urge anyone who sees opportunities to call me in, preferably, or call me out if I missed the mark, to tell me how I can do a better job addressing these issues. But I think they're critically important for us to bring to any discussion of perinatal care. So when we look at perinatal mortality in the United States, there are unacceptable and glaring gaps between non-Hispanic Black mothers and infants and non-Hispanic white. So for maternal deaths, the rate is 3 to 4 times higher for Black women than for white women. And when we look at infant deaths, they are twice as high for Black women as white women. There are also gaps for American Indian and American Native women, as well as Native Hawaiian and Pacific Islander women. So massive inequities exist. And these inequities are the direct result of structural racism. Part of this speaks to something called stratified reproduction. And the argument is that throughout the US history, the fertility and childbearing of poor women and women of color were not valued equally to those of white women. This is that authors go on to write in this essay that this is evident in a range of practices and policies, including Black women's treatment during slavery, removal of Native children to off-reservation boarding schools, and coercive sterilization of poor white women and women of color. Thus, reproductive experiences throughout the US history were stratified. The ideology of stratified reproduction persists today in social welfare programs, drug policies, and programs promoting long-acting reversible contraception. I think this is the thing, and this is really real. If you think about the TV show 19 and Counting, which is the family that has 19 children, that's a white family. There would never be a TV show celebrating a Black family with 19 children, because in America, the reproduction of white people is lifted up and valued, and the reproduction of Black people is considered to be a social problem to be solved. And I think that we need to actively counteract these attitudes and opinions. One framework to address this is the framework of reproductive justice. And reproductive justice goes a step beyond reproductive rights to talk about three fundamental rights. The right not to have a child, so that's access to contraception and access to abortion for those who don't want to continue a pregnancy. The right to have a child, so that's not being coercive in the administration of contraceptive methods, that's not sterilizing people against their will, and that's not having social policies that punish people who get pregnant while they're on, for example, traditional transitional assisted community families by saying, well, you don't get any benefits if you got pregnant while you were on welfare. And then third, and perhaps most fundamentally, the right to parent children in safe and healthy communities. So this addresses things like the school to prison pipeline. This addresses quality education. This addresses not being gunned down in the street if you happen to be a person of color carrying a cell phone. So this is a much more expansive framework that's grounded in human rights. And this book by Loretta Ross and Ricky Solinger is a wonderful primer on the nature of reproductive justice and the way it applies. Another must read to understand these issues is Dorothy Roberts' book, Healing the Black Body. And Roberts calls out the way that we've invoked contraception as a solution to social problems. She says, they say we don't need to spend money on social welfare programs or figure out racism and poverty. The solution is to keep these people from having children. And I think that as someone who's practiced obstetrics for 19 years, there have been more occasions than I care to admit that I've been really pleased with myself for talking someone into an Nexplanon because she doesn't need any more babies given all the things she's got going on. And that is not my decision. And if you hear yourself saying, whew, we got an Nexplanon in her, that's a good thing, you need to step back a second and reconsider, because that is perpetuating this idea that some people's babies are more valuable than others. When we think about this, it's important to distinguish between health disparities and health inequities. So health inequities are differences in health that are not only unnecessary and unavoidable, but in addition are considered unfair and unjust. Health inequities are rooted in social injustices that make some population groups more vulnerable to poor health than other groups. So I'm going to talk through a couple of examples. One of the really fascinating health inequities and downstream effects of structural racism is the enactment of Medicare in 1965. So this is Lyndon Johnson signing Medicare, and there were three parts to Medicare. Part A was what we think of as Medicare. It was a universal federal program to provide health insurance for folks over the age of 65. Part B covered outpatient care, and then Part C, which we know as Medicaid, was federal matching funds for states to provide medical care for low-income families who were receiving aid to families with dependent children, which is now TANF for welfare. So why was Medicare a federal program, but Medicaid was a state program? Well, the reason was that Southern Democrats weren't going to vote for a law that told them they had to provide health care to poor Black women in their states. And so Medicaid was administered at the state level. And that meant Medicaid benefits could be very generous, or they could be pretty terrible. How does that play out today? Well, this is from 2017, so I think there are a couple states that have switched over, but these are the states that have the total proportion of the population that is Black and current Medicaid expansion status. And you will see that the vast majority of states that have not expanded Medicaid are the states that are predominantly Black. And so as a result, uninsured non-elderly Blacks are more likely than whites to fall in the coverage gap because a greater share live in the states that have not expanded Medicaid. So because Medicaid was made a state program in 1965 to get Southern Democrats to vote for it, so Black people are still paying that price here 50 years later. This plays out in really interesting ways when you look at the gap between pregnancy Medicaid and Medicaid outside of pregnancy. So the federal level for Medicaid eligibility for pregnancy Medicaid is 138% of the federal poverty line. These are states that have not expanded Medicaid in 2019. I'm in North Carolina, and in North Carolina, you cannot get Medicaid when you're not pregnant unless you are in less than 42% of the federal poverty level. That's $8,727 a year if you were a woman with a dependent child. While you're pregnant, up to 210% of the FPL you can get insurance. But once you're done, you're out. And so what this means is that in Medicaid non-expansion states, women who are predominantly women of color because of structural racism and poverty don't have any health insurance once they're not pregnant anymore. And at 60 days postpartum, they fall off the map. So if that mom has anxiety or depression and is getting treatment, she doesn't have coverage for therapy anymore at 60 days. If that mom has substance use disorder, she doesn't have her opiate replacement therapy anymore. We know that opiate overdose, when women relapse, when they run out of insurance, is a leading cause of maternal death. So these issues have real consequences. California, of course, is far more progressive than North Carolina. But I was interested to see this paper that was recently published in PLOS One that looked at Medi-Cal and women's experiences of maternity care. And so comparing Medi-Cal to private insurance, women with Medi-Cal were less likely to feel that staff encouraged them to make decisions. They were 12 times as likely to feel that they were treated unfairly due to their type of insurance. They were 3 times as likely to feel they were treated unfairly due to race, ethnicity, and 3 times as likely to feel they were treated unfairly due to language spoken. So certainly Medi-Cal doesn't go away at 60 days postpartum, but women with Medi-Cal report being differentially and disparately treated during their maternity care. And that again is a function of stratified reproduction. She shouldn't be having babies. She can't even afford private insurance. That's sort of built into these experiences. And so we really need to be active about countering these stratified behaviors. I think it's impossible to talk about the postpartum period without talking about parental leave. And here again, California has been a leader as the first state to enact a state-based parental leave policy. But across the United States, 23% of women are back at work within 10 days of birth. 23% of women are back at work within 10 days of birth. At 10 days postpartum, you're still wearing those like stretchy mesh panties from the hospital and the big like diaper style pads, right? It's really hard to recover from birth if you're at work on postpartum day 10. Really hard to breastfeed if you're not with your baby on postpartum day 10. And yet, in the United States in 2012, 23% of women were back at work at day 10 postpartum. And what's even more problematic about this is when we think back to the importance of that baby being with the person who's caring for him or her and having that social engagement. What this means is that those with the least resources who can't afford to take unpaid leave or don't have access to leave because they have an hourly wage job are those least likely to be able to be with their baby. So in this marvelous review that I commend to you to understand this issue, Bertel and Bazruka write, the lack of policy substantially benefiting early life in the United States constitutes a grave social injustice. Those who are already most disadvantaged in our society bear the greatest burden. I think as we think about tackling these issues, I want to lift up this excellent work by a bunch of women from a group of women from California who are tremendous leaders. In an essay published, I think about 2 years ago now, they wrote, "There is no answer to solving this crisis that Black women do not already know. It is in their lived experiences and resilience that drives innovation and belonging, and we as stakeholders should take heed." So I'm hoping I've inspired you to think about these racial equity issues or that you're already thinking about them. But the solutions are not going to come from a group of healthcare providers sitting in a boardroom in a hospital brainstorming what people need. It will come from community engagement and listening to the women who are experiencing this care and having them lead and guide. They know what they need. They know what's missing. What they need is for us to listen. I also wanted to share a couple of books that have really helped me to begin to understand these issues, and California is heavily represented here as well. Dorothy Roberts' Killing Black Body, I've already mentioned. Harriet Washington's book, Medical Apartheid, is a searing account and indictment of the way that medical care in the United States has exploited, for both research and clinical care, the bodies of people of color. Fragmented Democracy is a fascinating book about Medicaid. And Jamila Michener explains that in states or communities where Medicaid is experienced negatively by those who use it, those folks are less likely to vote. So if there's a whole lot of paperwork to get Medicaid access, and if you have to wait in a really long line at the clinic, folks with Medicaid feel disengaged civilly and they're less likely to vote. So non-patient centered Medicaid is essentially a form of voter suppression, which I think is really interesting to think about, particularly in such a critical election. I've mentioned reproductive justice, which is fantastic. Battling Over Birth comes out of California, and I actually have my own copy sitting here. This is an amazing book, which I encourage you all to access and to read, that did qualitative interviews with Black women. I think this was based in the Los Angeles area, talking about what people needed and wanted and what was delivered and the gap between the two. The last is Tina Sachs, who's from UC Berkeley. It's called Invisible Visits, and it's about the experience of middle-class Black women seeking healthcare, and the ways in which women have to signal that they are capable and should be respected, and they have to dress a certain way and act a certain way to be taken seriously when accessing healthcare. And to think about the layers of additional work that women have to do to be heard because of racism and implicit bias, it really lays it out pretty powerfully. So I encourage you all to look at these different resources. So how do we make this better? Well, we can start by asking mothers what they need and value in the fourth trimester. And we've done this with the Fourth Trimester Project. We have a very active Twitter, Facebook, and Instagram presence, so I encourage you to follow our work. And we are really trying to transform the lived experience of the fourth trimester through a national movement to spark real sustained change through women and their families. We did this through stakeholder engagement. So this is one of our team meetings, and I want to just highlight a couple of things. The first meeting we had, this was not the first meeting, we held at a hotel in a conference room, in a conference, the way you do a conference. And we told the participants, which included postpartum moms, to wear business casual. And the mom said, we are 3 months postpartum and our business casual does not fit. And we don't like that we're here in sweatpants and then the doctors are here and the nurses are here in like business casual. So we designed a t-shirt for our big stakeholder meeting the following year. Everyone's wearing the same t-shirt. So there's no like doctors are in nice clothes and moms are in sweatpants. And instead of having it at a conference room at a hotel, we had it at a local children's museum. So we basically rented out a birthday party room and we had the conference there, and we comped admission to the children's museum for the older siblings and other members of the family, and then had meals that everybody could join in the birthday party room. So it became a fun outing day for the rest of the family while the moms were engaged in the stakeholder work. So I want to share a couple of the themes that emerged. One was about sleep. So this is a little light humor as we're going through some pretty heavy topics. My personal favorite here for baby sleep positions is H is for hell, which may be familiar to some of y'all. There's also the roundhouse kick, which is a common thing, neck scarf. There are a lot of ways that babies intentionally or unintentionally, and when it's unintentional, it's considerably more problematic, end up in bed with mom and dad. So one of the things that women said is that we need to reframe the discussion about infant sleep. It's about the woman's quality of life too. And this was in response in part to AAP guidance, which stated that it's optimal for the baby to sleep in the same room as the parents for the first year to minimize SIDS risk. And while there's epidemiologic evidence to support that, if you have a paid work to do during the day the next day, and the baby is fussing and snorting and making noise during the night, keeping the baby in the parents' room in a separate sleep service for the first year can be pretty darn disruptive. And nowhere in that document does it say, although this is advantageous, a shared decision with the family about what's feasible needs to be considered. It just says, do these things or else your baby might die of SIDS. And so I think thinking about how our sleep recommendations align with living and surviving the postpartum period is a really interesting example of how we can reframe postpartum care. There's a quote from another one of our participants. My physical recovery had a lot of bladder incontinence. I kept thinking, I'm never going to be able to feel the need to pee again. She described that she'd had a 5-hour second stage, had pushed for a long time. I'm not clear when her Foley was placed or removed or emptied, but she got up to postpartum and had overflow incontinence. So she stood up and peed all over the bed. And so she called the nurse, and the nurse said, oh my God, that's disgusting. What's wrong with you? Can't you control your bladder? Instead of saying, ma'am, I'm so sorry this can happen. Well, she continued to have overflow incontinence. And her OB said, well, you don't have a UTI. I don't know what your problem is. So she Googled, as one does, and she discovered that there is such a thing as pelvic floor PT, and she stopped wearing Depends after several pelvic floor PT appointments. But to not be able to offer women support other than, well, I guess you'll need to buy Depends is really problematic. And you can imagine it's not good for your mood if you have to wear Depends. So if we're thinking about maternal mental health, we need to think about what's going on within the body. This is one that is particularly germane to the conference that we're convening today. Mom said, if I score too high on the EPDS, will they send me to an institution? Are they going to take my baby away? And what we learned is that moms make a calculated decision when they fill out that EPDS. And they wonder, is this about helping me, or is this about checking to see if I'm a good mom? And if they're not sure, they're going to lie. It's not hard to tell what the right answers are in that test. And so it's really important that we establish trust with our patients rather than just handing them a piece of paper and assume that they're going to tell us their sort of most intimate fears if they don't know that we're not going to use it to harm them. Whoops, I'm having problems. And then there's sex. So this is a quote from one of our participants. Not wanting to have sex can be a strain on a marriage, and not all men understand it. And the way a physician says can doesn't mean should. So her story was she came to her 6-week postpartum visit, and the physician did a pelvic exam and said, great news, your bottom's healed, you can have sex again. And she said, well, I know that's what my husband thinks is going to happen tonight, but I do not want to do that. And I don't know how to navigate that. What do you recommend? And her provider said, well, that's how I felt after our kid was born, and now I'm divorced, which basically turned into just put out or else you're going to be a single mom. So she was alarmed. I've shared this story in lots of fourth trimester discussions, and someone said to me, well, the reason that she's divorced is because she said things like that, not because she wouldn't put out for her husband. And I think they have a point. But I think that it, to me, represents how ill-prepared obstetricians are to offer usable, actionable advice for women who have this expectation from their partner and this, oh my God, I've been covered in goo all day, don't touch me kind of situation. So interestingly, this patient directed us, our team, to this fabulous episode of the Longest Shortest Time podcast. And this is Dan Savage and Jane Marie talking about the Parent's Guide to Doing It. And Dan Savage, who many of you may know, is a gay man and a sex columnist and a huge advocate of lots and lots of sex, said that when he and his partner adopted a baby, his partner was the stay-at-home parent. And Dan would come home from work and his partner would be like, dude, I've been covered in body fluids all day long. Do not touch me. And that was a really mind-opening for me, because I think I had in my head that, well, it's the breastfeeding and it's the birth and it's your vagina being stretched out. But no, if you're covered in body fluids, you don't want to touch people. And I think normalizing that for families and letting them know that some people are interested soon and some people are not interested for a really long time. And if one person's not interested, the other person has two hands and they can pleasure themselves. And eventually this will come back. But I think we need to be really candid with folks, because there's a lot of suffering when there's a misunderstanding of what's needed. The other clinical pearl or life tip, I guess life hack in this podcast, which is really excellent, is that Dan talks about when you finally get a date night and the babysitter's coming and you're going to get to leave the house. And this is maybe irrelevant because in COVID there is no date night, right? But let's imagine there is a babysitter and you're going to leave the house. Go ahead and do the intimacy first. Because if you go out to dinner and somebody has an extra glass of wine, or like the dessert doesn't sit well with them or whatever, and you get home and one person doesn't want to and the other person's disappointed, just do it first. So no matter how old the kids are, this is highly useful advice. And I know I'm coming up on time, so I'm going to keep moving. So I just wanted to close with thinking a bit about how we might provide better care. And I've been really moved by this quote from Chanel Portia Albert, who is a doula and birth activist from New York. And she says that during birth and postpartum, every woman should be able to say, I am seen, I am heard, I am loved. And if we were to center care in this way, so that every woman could say that, it would make an enormous difference toward improving the quality of care. So there are a couple concrete ways I think we can accomplish this. One is by really embracing shared decision-making. Shared decision-making brings at least two experts to the table, the patient and the provider. Providers are experts in the clinical evidence, and the patient and her family are experts in their experiences and values. And so rather than a paternalistic model where I tell the patient what to do, or an informative model where I say, here's some options, what would you like to do? I elicit values and preferences, and then I share information and recommendations, and we make a decision together. I share this slide a lot on social media, and a colleague of mine said, I don't think you quite got it, because it's not just one provider, it's a team. And particularly for Black and Indigenous people of color, it's not just the patient, it's for the patient and her family. And so we need to bring all those folks together to make a shared decision. It's also really important to remember that a shared decision does not mean that the patient shares the opinion of the provider. So if every single time they end up doing what we say, we are not making a shared decision. And that can be annoying when we think we know better. But the whole point of shared decision making is we don't know all the things, and we have to make that decision together with the patient. So thinking about how to do that concretely, I grew up waking women up at 5 in the morning on rounds and saying, what are you gonna use for birth control? And there's a problem with that. When we think about stratified reproduction, if that's a young mama of color and someone's waking her up at 5 in the morning saying, what are you gonna use for birth control? The take home of that might be, do you think I shouldn't have more babies? Is there something wrong with me having babies? So instead, now I ask, do you think you wanna have another baby? And if you do, when do you wanna have another baby? And if she says, hell no, then I say, well, what are you planning on using for contraception? And if she says withdrawal, then I can say, well, withdrawal and hell no, those don't totally align. Like, let's talk about this a little bit. Or if she says as soon as possible, I can talk about birth spacing and say, we really encourage women to give their bodies 18 months to heal and their babies some time to grow before they get pregnant again. You know, can we talk about that? But if I just say, what do you want to use for birth control? I miss that opportunity. And so that's just one way how we can change the conversation. I think it's also important to tell mamas what to expect. Elizabeth Howell, who's a national leader in this area, developed a 15-minute intervention that went over common symptoms in the postpartum period and how to manage them. So for bleeding, it explained that lots of women have bleeding for a full month after delivery, that you should wear a pad and don't wear white. Like, it was very concrete and specific. And what they found was this 15-minute information session in the hospital, followed by a phone call at 2 weeks, reduced elevated depression scores through 6 months postpartum. So just telling mamas what to expect can make a huge difference. Toward that end, our team with the Fourth Trimester Project has developed newmomhealth.com, which is the first national postpartum information source designed by moms for moms. Our values are very much centered on shared decision making. We believe that healthcare information should be honest, accurate, clear, high quality, and based on the most current science. We believe that women are resilient, strong, and capable of making quality decisions for themselves and their families. And we believe that communities and health systems should care for the mother rather than demand that she access care. So we co-designed this website with input from a variety of moms groups, and they helped us to name these different sections. So I think at one point we had perineum here, and they said, what is that? And we changed it to bottom and pelvic. We had mood and depression, and they said, no, we don't want that. We want emotions and hormones, because that sounds less stigmatizing. So they came up with these different sections, and it's all searchable. And in addition to common health issues, there's a section on building my village, which talks about things like trusting my partner to take care of my baby, dealing with helpful and not so helpful friends and family who come in and offer opinions that are not wanted. So it's really about both the physical and the psychosocial and emotional experience of the postpartum period. Salud Mama, which is the Spanish version, is going to launch in late October, which we're really excited about. This is a free resource, and I encourage you to share it with your patients. So a couple minutes over, I want to say that the weeks following birth are a critical period, and our current systems of care do not meet women's needs. Structural racism compounds these challenges and requires us to take active steps to mitigate it. We can improve care by sharing guidance about what to expect, by asking women what they need and value, by elevating their strengths and sharing decisions, and by ensuring that every woman is seen, heard, and loved. And I want to close with a quote from Joya Crear-Perry, who's one of my sheroes. What would it look like for women to not only survive pregnancy, but to thrive? Thank you.
Thank you, Dr. Stubbe, for an incredible presentation. I want to offer the opportunity for people who have questions who've been watching this presentation to submit them to me via the Q&A function at the bottom of your screen, and I'll be sharing them here with Dr. Stubbe. So Dr. Stubbe, our first question is, how can medical providers support mothers in a more integrative way when time is very limited at an office visit? My experience has been if I don't mention how I am feeling, they will not address it. And when addressed, the information is very superficial and meaningless for the patient.
Yeah, so one of the questions I like to ask is what's going well? And sometimes there's a long period of silence and that tells you something. Sometimes and that inevitably devolves into what's not going well, but it lets us know what's most important to her. So for example, I do a lot of work around breastfeeding, and sometimes people tell women, well, why don't you just give the baby a bottle and then you'll have some time to rest and you won't be so tired. But if she says, what's going well, when I breastfeed my baby, I feel amazing and I feel like I'm a good mom, but the rest of the time I'm exhausted. Well, telling her to stop breastfeeding is not the solution, right? So asking what's going well gives you a sense of what her strengths are and lets us focus on lifting those up. I think another piece of this is who decided that 15 minutes is enough time to provide prenatal care. And so I think we need to band together and advocate for appropriate coverage. And we also can bill for postpartum care if it is outside the scope of the global. So if the patient has an EDRA of 19 and is depressed, you can put a modifier 24 on that ability and a visit, and you can spend an hour with the patient. Obviously, if you have 2 more patients booked in that hour, that's a problem. But this idea that we can't bill for postpartum care so we can't provide it is not actually supported by billing guidelines. And then lastly, I think we need to be really creative about, who are the right people to provide support in the postpartum period. So if a community health worker who has lived experience may actually be a better resource for a mom than an MFM. And so if I have a community health worker embedded in my practice who can spend some time with mom and talk about her concerns and issues and then come to me with, okay, so I either want an Nexplanon or an LNG IUD and I'm not sure which one, and here are my questions, then we can provide our medical expertise and someone else can help with some of the psychosocial issues and what's the fun of the diaper bank and that type of thing. So I think if we're creative about who does the staffing and don't assume that the doctor is the one who knows all the things, because I'm probably a lot less useful to somebody than a culturally aligned community health worker for a lot of things, then we're able to provide that care without that being an hour of time for someone who could be doing a hysterectomy, which is more billable. So that's sort of a multi-phased question, but I do think what's going well goes a long way toward understanding. And then what's the most important thing for you for us to address today? And then you can bring her back for another visit if we haven't gotten through all the stuff, right? And bill for that as a separate visit. So those would be some ideas that I would share.
Wonderful. So we also have a question about, could the first 3 weeks of contact with postpartum mom be by televisit or in person?
So anything that works for you. We were very careful not to say in person because especially if mom lives an hour away, getting her and her baby in a car seat and dragging herself to your office for a face-to-face visit may not have any value add. So that could be a phone call. That could be a lot. There are, patient portals built into lots of EHRs where you could send a questionnaire saying, how are you doing? And are you having any of these symptoms? And if you have questions, call this number. I think there are a lot of ways to do it. But the idea is waiting until 6 weeks without any kind of outreach is probably not good for mamas.
Okay. We also have another question for the Black mortality after birth. What is the biggest thing that moms are dying from?
So I think one of the key drivers is cardiovascular complications, so peripartum cardiomyopathy, hypertension, stroke. And so I know CMQCC has a great toolkit around cardiovascular disease and recognition. One of the things that I certainly see, and I know a researcher out of UCSF gave a talk at ACOG about this, so I assume it's true in California as well, is that moms present to emergency departments and their severe range blood pressures aren't classified as a problem because in a person with hypertension, a 163 on 112 is not that bad. And they get ranked as a level 4 acuity and they get sent to the backside of the ED and nobody cares about them. And if that person is having postpartum hypertension and their normal pressure is 90/60, they're at risk for a stroke. So I think ERs are one place where we need to do a lot of work to educate folks to A, find out if the woman's recently pregnant, and then B, know what to do with that information and know that the differential diagnosis is different. Similarly, peripartum cardiomyopathy, I'm tired. Well, you're postpartum, of course you're tired. Go home, what's your problem? As opposed to, wait, you're tired and you're saying you're short of breath, and I think I hear crackles, you need an echo. You're not just a person who's postpartum and she's tired. So I think that those are some of the key preventable causes. And then suicide and drug overdose, which is where we need to really be thoughtful about screening in a way that doesn't make the patient think we're surveilling her, and then making sure that she doesn't fall out of care if her insurance status changes. So.
Wonderful. We also have a question. How do you view postpartum nurse lactation consultant home visitation programs to check in on those topics you discussed that should be assessed early on? Could you recommend resources for any home visitation programs like Family Connects?
So Family Connects is marvelous, and they were born one county over from me. My house is 100 feet from Durham. So Durham County was originally Durham's Connects, and that's an excellent program that is a universal touch point I believe their home visit is at 3 weeks postpartum, but they make phone calls earlier. And they do a really comprehensive assessment of mom and baby. In the 90-minute version of this talk, there's a slide about them. I'm sorry it got cut in the effort to fit into 45 minutes. But I think that's a great program. And one of the things that was really fascinating is that when they did the program, they found that everybody had some need for connection to a resource. So you couldn't say, well, it's just first-time moms, or it's just first-time moms for under 25, or it's just moms who have a depression history. Everybody had something. And so that intentional connection and assessment of the dyad, so we're thinking about mom and baby together, reduced ED utilization. I think they figured for every dollar invested, they saved $3 in ED visits. So it's got a very, and that's just baby ED visits. So for a health plan, this is a great deal, and we should be providing that. I think lactation consultants have the orbicular interface skill set down, which is great. I'd want to make sure that that LC also had the training and orientation to assess the mama and baby parts other than right here, which many LCs know intuitively. But we just need to make sure that's all built in there so it doesn't just become, well, the baby's latching well. And I'm not sure about your headache and your blood pressure, but I'm just talking about the boobs. So we need to make sure we have all of those pieces together. One of my dreams, and if someone wants to fund it, please contact me, is to come up with a sort of certification module that would look at all the different realms of mama-baby care in the postnatal period. And if you're a lactation consultant, you can skip the breastfeeding modules because you got that. But reviewing stuff about preeclampsia and reviewing stuff about baby complications and things like that might be important if you're a pediatrician. You don't need to know if the baby's turning blue at day 10, that might be a coarct, but you might need to review what preeclampsia looks like, and if mom has a bad headache, you need to be on top of that, so that everybody could be prepared to identify this is someone who needs escalation of care, and I may not know how to treat it, but I know it's a problem, and be able to be familiar with those warning signs. So that's actually explicitly referenced in the postpartum safety bundle that was put together by the patient safety, the Safe Healthcare for Every Woman, and the AIM bundles.
So Dr. Stubbe, we have quite a few requests for you to post the fourth trimester project website again. A lot of people are trying to access it, so if
Absolutely.
you could share that slide.
I'm putting it in the, oh, that's the panelist chat. That's not going to help you. Hang on, let me go back to the slide. I can actually, let's see, share, and I will go backward to here. It's newmomhealth.com. And it will be Salud Mama. I think we've got the .com domain, but it will be newmomhealth.com/es for Spanish. Will be coming out in the end of October. And we've worked with Urban Strategies, which is a group that does a lot of patient engagement in the Latina community, to not just translate, but to actually culturally adapt the content and have the images be reflective of Latina Latinx communities, so that it's not just a literal translation, but a cultural adaptation. So we're really excited for that launch, which will be in late October.
Great. And I think we have time for just one last question here. Can you speak a little bit about resources for surviving the fourth trimester during COVID? A lot of families have limited resources and support at this time and are more isolated. What are some tips you might have that may help people navigate during this time?
Yeah, so there's actually a specific section on New Mom Health about COVID for new moms that talks about some of those issues, and I'm just going to see if I can pull that up and share it successfully. What are you guys seeing right now? I think I'm sharing PowerPoint, not this. On the fly sharing here. Yes, here we go. So this specifically looks at emotions and isolation and daily life and breastfeeding and support people and being safe and postpartum care planning. There's also Jenny Joseph, who's an amazing midwife and thinker around postpartum care, talks about birthing people in COVID. So these are this would be my first go-to resource. I think that the isolation in the face of the village that is biologically necessary is probably one of the hardest parts. And I think this is something to address in antenatal care. You know, can you sort of bubble with grandma or auntie or cousin or some other person? And that's really hard because grandma may be in another country who can't come here, or maybe in another state and doesn't want to get on an airplane or get in a car. So I think it can be really, really challenging. We talk a lot in the COVID for New Moms section of the website about, physical distancing doesn't mean emotional distancing. And so being really intentional, I know Zoom is not the same as real life. I wish I were all there with y'all and we could all be going out to get a glass of wine tonight. Um, but sort of setting up the how am I going to keep up with my people, and scheduling that when people can't drop in physically. I remember one of the hardest things about the fourth trimester being that I didn't have anyone to talk to who spoke in complete sentences. And that was very, very tiring. So if someone pops up on the screen and can send a Grubhub to your house, like it's not the same as them coming, but you can start to do some of that. But I think it's really hard. And I wish I had a solution more than that. So.
Okay, this has been wonderful. We have quite a few requests for these slides. If you are interested in receiving the slides, you can contact me directly. But overall, we just want to say a very warm thank you to Dr. Stube for joining us today. We were thrilled to have you present.
Well, thank you so much for the invitation, and absolutely happy to share the slides. I usually put them on Twitter, which I just haven't gotten to yet, but I will, so I'll tweet them out. Is there a hashtag for the conference?
There isn't, but if there's a way you want to share that with me, I can share it with our marketing team.
Perfect.
All right. Well, we will be taking a short break, and we will return in 15 minutes for our peer panel. Thank you.
Thank you.